I invite our President-elect of the TamilNadu Association of Neurological Surgeons, Dr. Suresh Jayabalan sir, to give the welcome and inaugural address.
Thank you, Babuji. First of all, I like to thank Dr. Rajesh Babu for organizing such a wonderful webinar continuously. Because of his effort only, we are doing this every month without any problem. I like to thank today's speaker, Dr. Arul Selvan, who is the senior consultant neurologist working in the Royal Care Super Specialty Hospital, Coimbatore, for giving this very good lecture on the Alzheimer's Day. On behalf of TamilNadu Neurosurgeons Association, as well as on behalf of our President, Dr. L. Murugan, I welcome you, sir. Unfortunately, our President is not available. He is traveling today. And on behalf of the society as well as the office bearers, we welcome you all. I thank Dr. Sridevi, who is the senior neurosurgeon at Royal Care Hospital, being a panelist. And I thank Dr. Ganesan, who is a senior neurologist at Erode Preeti Hospital, for accepting the invitation being a panelist. Thank you very much, sir. I once again welcome all the delegates for this talk. I hope you all will benefit from this talk about the Alzheimer's Day and Alzheimer's disease and all those things. Thank you very much. Once again, we'll proceed. I hand over to the Secretary, Dr. Rajesh Babu. Thank you.
It is time for the Secretary's report. We, our Tamil Nadu Association of Neurological Surgeons, are routinely doing the monthly CMEs every month. We are doing at least one CME per month. The important, the national and international days we are celebrating. Along with that, we are thinking in terms of conducting a CME program also. Along with that, we are getting one credit hours also, we are getting it. Because nowadays, the credit hours are more important for all the doctors. Now it is that they have given, it's very compulsory and all those things. And today's speaker being the Dr. V. Arul Selvan sir, going to talk on recent advances in Alzheimer's dementia, and the panelists are there. And at this juncture, I welcome you all, Dr. Arul Selvan sir, Dr. Ganeswaran sir, Dr. Sridevi madam, and Dr. Aruna Devi madam. She told she is not feeling well, that's why she is not joining actually. And at the same time, I invite our observer from the TNMC, Dr. Saravanan sir, Saravanan Vedagiri from Chennai. I welcome you all, and we will straight away go to the program. And now, Naveen, introduction. Dr. Arul Selvan sir is the consultant neurologist from the Royal Care Super Speciality Hospital, Coimbatore. And he is completed his DM Neurology from the Institute of Neurology, Chennai. And he was appointed as the consultant, worked for 7 years in the Walton Center of Neurology in the Liverpool, England. He is interested in neuromuscular disorder, epilepsy, movement disorder, stroke, interventional headache, and nerve conduction and EMG studies. He has done innovative techniques like intrathecal baclofen pump for chronic spasticity. He has written articles in peer-reviewed international journals. He is a member of Association of the British Neurology, Indian Academy of the Neurology, and British Society of the Clinical Neurophysiology, and American Academy of Neurology, AAN. And he has conducted several courses, workshops, and innovative lectures. And he has been awarded fellowship by Royal College of Physicians, London and Edinburgh. He has also received the Lifetime Achievement Award by Lions Club International. And he was very much instrumental in bringing the MRCP, FUGS, the treatment for the Parkinson's disease in Coimbatore. He was very much instrumental in doing it.
Good evening, everyone. At the outset, I would like to thank the Tamil Nadu Association of Neurological Surgeons for giving me the wonderful opportunity. I thank the President, Dr. Murugan, who was contemporary when I was working in the get trained in the Institute of Neurology at Madras Medical College. and also the President-elect, Dr. Suresh Jayavalan, and Dr. Rajesh Babu, the Secretary. I also like to thank my panelists who was very kind enough to come, Dr. Sridevi Madam, and also Dr. R.A. Ganesan and Dr. Aruna Devi. Let me tell you one thing, that this lecture is not intended for neurologists. This is intended only for general physicians and postgraduates, and also some neurosurgeons who have come across these type of patients in their clinical practice. So Alzheimer's dementia, an update. So we all know that it is the disease of the elderly population. Dementia is very common in elderly. The prevalence of the disease doubles in every 5 years. The prevalence does vary from different countries to different countries. In the Western countries, it may be the incidence a little bit high because of the longevity of the life. And the heterogeneity can be explained by the difference of age, tests used for cognitive and functional evaluation, and the diagnostic criteria in the rural and urban areas, and also the representation sample. I'll just touching the background. Initially, I'll give the background of the dementia, and then I'll go into the detail. See, the United Nations population divisions aged above the 60 is growing up over the years. The global scenario of the elderly population is going to increase. Population in India of the 60 plus is also going up. In 2051, it's going to be 17.3 millions. The socio-demographic profile of the elderly in India, particularly is the elderly persons lives in rural areas, is quite common. Out of 50% of them are women. Illiterate and the independent are 73%, and 66% are very vulnerable in situation without sufficient food. Life expectancy is going to go up, and we already know that it's going to cross 70 years soon. And these type of patients to have potentially to have an Alzheimer's dementia. When the literacy rate goes up, the longevity of the life is also goes up, especially that's true in Kerala and Himachal Pradesh and Tamil Nadu. You can say the literacy rate is very high at about 10%. It is setting up the global burden of the disease. Study suggests the dementia and other neurodegenerative disorders is the largest source of disease burden. Significantly increases the healthcare cost, influences the quality of life and caregivers. So huge socioeconomic burden. I'll start off with the case. I hope Dr. Suresh Jayavalan will remember this patient. He's an 84. Just to give a sample of treatable dementia, how it is important to take appropriate clinical history and also the examination to give us a clue. He has a progressive memory loss for 3 months, admitted with drowsiness for 1 day, and then he had a positive right-sided movements immediately on the day of admission. And the right arm, right leg is weak in the plantar extensor. He had a similar to stroke, and then he had a right hemiparesis. You could see that bilateral chronic subdural hematoma. He was operated and he got better. And this patient was treated as a dementia for some time before we found out that it's a treatable dementia, it's treatable cause. So what is dementia? The disease of the brain that causes a decline in the memory and intellectual functioning. Previously higher level of functioning goes down from severe enough to interfere with everyday activity. This is not the normal aging. We'll discuss about the normal aging. Dementia is a declining in the mental state, including the memory, that is severe enough to result in the loss of independence in typical daily activities. Dementia is most common in older adults, but younger dementia can also happen in autosomal dominant form. Alzheimer's dementia is the most common out of all dementias. It's quite common in women. Majority of the time it does happen at the 6th or 7th decade. But sometimes it can start as early as 65 and 60 when you have a strong family history. It is estimated by 2025, over 34 million people worldwide will suffer from dementia. So dementia is a common umbrella term that includes any type of dementia which comes, but most commonly we call it as Alzheimer's dementia, but there are other dementia is also there. Vascular dementia, dementia with Lewy body disease, frontotemporal dementia, other rare causes of dementia like Creutzfeldt-Jakob disease. We'll talk in a little bit more. As I told you earlier, the dementia is a common umbrella term. It does come with the Parkinson's dementia, Lewy body dementia, vascular dementia, and the frontotemporal dementia, other dementias, which needs to be identified. So what do you think the Alzheimer's disease is? It's a group of symptoms, not a single disease. It's the most common cause of the problem with the memories, and behavior, and thinking. Vascular dementia is the second most common cause. is more than memory loss. There is a sudden changes in cognition, personality changes, impaired judgment, inability to perform the activities of daily living is also important. Other types of dementia, the frontotemporal dementia, predominantly affecting the frontal and temporal parts. In addition to the memory loss, they can also have a speech difficulty, identification, change in behavior and language. Dementia with Lewy body disease, they have a prominent visual hallucinations, which is very characteristic and hallmark of the disease. When any patient who comes with visual hallucinations along with the dementia and a little bit of extrapyramidal signs and symptoms, you always think of dementia with Lewy bodies. And then some patients may have a combination of mixed dementia, like for example, they may have a recurrent stroke. So vascular dementia and Alzheimer dementia can also overlap. We cannot categorically diagnose one dementia at all. As I told you earlier, the Alzheimer's dementia is the most common type. Alzheimer's is causes of problems in memory and thinking and behavior. It's the most common form of dementia. It's a normal part of the aging is not is a dementia, but Alzheimer's worsens over the time. Unfortunately, they do not have a current cure. So what is Alzheimer's disease? This is a German psychiatrist, Alois Alzheimer, in 1906. He saw changes in the brain tissue of a woman who had died an unusual mental illness. She had a memory loss, language problems, and unpredictable behavior. And he found out with the autopsy that he had an abnormal clump. She had an abnormal clump caused, which is later on identified as amyloid plaque, and tangled a bundle of fibers, neurofibrillary tangles or tau proteins. In 1910, the Emil Kraepelin, who suggested the Alzheimer's disease name. So there are various stages of the Alzheimer's dementia. Is there the preclinical minimal cognitive impairment is a mild form of dementia. In fact, it's the onset of the dementia process. So any disease modification which can be tried at a minimal cognitive impairment, the disease progression could be arrested. So the mild dementia and the moderate dementia and severe dementia. So what are all the symptoms? We will discuss in detail about the symptoms, but apart from the memory loss, they can also have a poor judgment and decision making, which is strikingly visible. Inability to manage a simple budget at the day-to-day activities of the household activities, losing track of the date of the season, difficulty in having a conversation, misplacing the things and being unable to retrace to find them. As I told earlier, the preclinical state will not have any symptoms. The minimal cognitive impairment will progress to a rapidly forming dementia, and then it will take some years to develop the full-blown dementia. We discussed the stages of dementia, early stages of dementia, middle, and then severe stages. Early stages, they can have a slight confusion. They might need some extra support. Most of them, they will manage activities independently. Minor changes in behavior like irritability and depression, emotionally upset, can be mistaken as a process of aging. This is the early stage. Middle stage, the changes become more marked and can become more forgetful. They need support at the day-to-day activities. At this stage, people can become easily upset, angry, and aggressive. The late stage, the person will be unable to do any simple task. They need support and help constantly, including the brushing, shaving, wearing the dresses, and bath. The mobility can be affected, could become confined to a bed or wheelchair at the later part of the disease. So common signs of dementia is a memory loss. New learned information will be defective. That's very important. And apart from that, they'll have a disorientation to time, place, and people, language problems, diminished concentration, spatial perception problems, difficulty in performing the complex tasks. So the early stages we can identify before it goes into the full-blown disease. The early stage usually takes about 2 to 4 years in progression before it goes into the middle stage, which sometimes take 2 to 10 years into going to the advanced stage, depending upon their educational background, health, comorbid conditions, and the family history. The late stage only they last up to 1 to 3 years, and invariably they die within a period of 3 years once they enter into the late stages of Alzheimer's dementia. What is mild cognitive impairment? A decline in the cognitive function that is normal, that is not normal in aging, but it's also not severe enough to impair the daily activities which warrant the diagnosis of dementia. 15 to 20% of the patients above the age of 65 do have a minimal cognitive impairment. Those with minimal cognitive impairment are likely to develop Alzheimer's disease, but not always. When cognitive impairment due to Alzheimer's disease symptoms usually start gradually and progress slowly over a period of many years, talking about 5 to 10 years. In early stages, the memory loss is very mild and subtle, but in the late stages, the memory loss will be more marked and then it can be easily identifiable. Unfortunately, there is no cure for the Alzheimer's disease. Level of education is also important. It does have some correlation with the CNS damage, central nervous system damage, comorbidities and prolonged illness, head injury, dietary deficiency, especially vitamin B12, and then alcoholism and abscess. Studies observe that low level of education is consistently associated with a higher prevalence of cognitive decline, which is well known, and it's proven in cross-sectional and cohort and longitudinal studies. So the pathology, we all know that the 3 important steps is pathology. The early stages of Alzheimer's dementia do have a forgetfulness, trouble in multitasking. They often writes reminders but loses them. Personality changes. Suddenly they'll become violent, or they could become aggressive when you pointed out the wrong mistake they do. And then they can be depressed also emotionally. They can have tears. So sudden personality changes and then changes in personal appearance also. The differential diagnosis of dementia, as I told you earlier in my case vignette, there is a treatable cause of dementia also, which can be potentially easily treatable with a simple burr hole. But other causes including the CVA, Parkinson's disease, traumatic brain injury, HIV encephalopathy, advanced stages of multiple sclerosis, Huntington disease, Lewy body dementia, frontotemporal dementia, Creutzfeldt-Jakob disease, solvents and chemicals abuse, chronic hypoxia and obstructive sleep apnea, syphilis and Lyme's disease, brain tumors, especially the temporal lobe tumors, normal pressure hydrocephalus and Wernicke-Korsakoff's. Early detection is very, very crucial. Fewer than 50% of the cases of dementia are diagnosed in clinical setting. Family members and healthcare workers are more important to play a crucial role. Better diagnostic aid is needed, which is culturally relevant. We can do that on the own language. What are the 10 cardinal important signs of Alzheimer's disease? We will go by one. I'll just start up with the first one. The memory loss that disrupts the daily life. Forgetting recently learned information. The recent things they might got forgot, but the olden things like date of birth, wedding days, the date of joining, the last place of work, they'll all remember, but forgetting important people who met them in the last week, what they had for dinner, they cannot able to identify it. The age-related changes, sometimes they're forgetting the names and appointments, but not in Alzheimer's disease. Challenges in planning or solving problems. Changes in the ability to develop or follow a plan. Changes in the numbers, they have a difficulty in cope up with the numbers. Trouble following familiar things, especially when they want to cook, they cannot follow that. Trouble keeping track of monthly bills. Difficulty in concentration, they have a poor attention span and they get easily distracted and also get annoyed and grumpy, as old age people do. Whereas the age-related changes, they do have only occasional errors, but not often. Difficulty in completing the familiar task at home, at work, or leisure. Driving to a familiar location, they find it difficult. They get lost, and then the police or the traffic warden can bring them back to home. Occasionally needing help to use the settings in a microwave or to record a television show. That's what the normal aging people will do when they advance. Whereas Alzheimer's disease, the confusion with the time and place, they turn up into the wrong time and wrong day to the festivals, and sometimes forgetting where they are, how they got there. Age-related changes, occasionally they get confused, but not often. Trouble understanding visual spatial problems, visual spatial disorientation, apraxias, agnosias can happen, especially when they have a posterior parieto-occipital cortical atrophy. They have a posterior syndrome, that's what called. They have a vision problems, difficulty in reading, trouble judging the distance, and difficulty determining the colors and contrast may cause problem. And the final stage, they may have a cortical blindness, which is called Huntington syndrome. New problems, the words and speaking Alzheimer's disease, they may find it word finding difficulties. They make errors. For example, instead of calling the doctor, they may call his wife. So stopping in the middle of the conversation and no idea how to continue that. They can repeat the same thing again and again. Struggle with vocabulary, that's called naming difficulties or anomia. Problems finding the right word, call things by the wrong name. But whereas the age-related changes, that will not happen. Misplacing the things and losing and the ability to retrace them, putting the things in an unusual places. For example, wallet can be put in the shoe rack, or keys can be kept somewhere else in the lunch box like this. So losing things and unable to trace them, whereas age-related changes, they just misplace and then they take some time to find out. Decrease or poor judgment, changes in the judgment or decision-making, lose attention to grooming or hygiene. Personal hygiene can be poor in Alzheimer's patients. So they often withdraw from the social activities. That's very, very important. We need to early sign, identify them. They don't want to come into the social function. They becomes withdrawn. So they don't want to mingle with the crowd, and trouble remembering how to complete a favorite things, especially how we avoid being social. Changes in the mood and personality, they may be confused. Paranoid ideas may come in, depression and forgetfulness, anxiousness, easily upset at home, at work, with friends, or in places out of comfort zone. But age-related changes will not have all these problems. How do you diagnose Alzheimer's dementia? There is no specific test, but there are some cognitive mini-mental status examination tests like this, and then it could distinguish from the other dementia. Careful clinical history, medical and family history to find out whether there is any autosomal dominant inheritance in the Alzheimer's dementia. Physical, neurological, and problem-solving memory. Routine blood tests just to make sure that they are not vitamin B12 deficiency. Or hypothyroidism can also cause memory loss. Just find out at the right time. These are all some of the cognitive assessment in dementia. Mini-mental status examination does take about hardly 5 minutes to assess. You have a score of 30. Less than 27 is called early dementia. And then less than 20 is called the moderate to severe dementia. Less than 10 is severe dementia. Abbreviated mental test, cognitive 6CAT, Montreal Cognitive Assessment, Addenbrook's Cognitive Assessment, Cambridge Assessment of Memory and Function. And you could see how markedly this Alzheimer's disease brain has been atrophied. This is a normal one on the left-hand side, and the abnormal shrunken cortical and sulci is so prominent on the right side, indicating severe neuronal loss and axonal damage. So clinical-based evaluation, interviewing and history taking, physical and neurological examination to find out other causes of dementia and sometimes treatable dementia like subdural hematoma. Cognitive assessment, depression screening, functional status, medical history and review, medication review, laboratory tests, and brain imaging to exclude treatable causes of dementia like a normal pressure hydrocephalus. And you can repeat the evaluation in 6 to 12 months if the cause is unclear. Mini-mental status examination, mini-cog examination, Montreal cognitive assessment. Out of all these things, we found a Montreal cognitive assessment is more sensitive, specific, and then highest security, highest specificity and sensitivity. Brain MRI is to find out to exclude normal pressure hydrocephalus, other patient dementia mimicking like subdural hematoma, temporal lobe tumors, hydrocephalus. But brain MRI is very crucial to find out also the temporal lobe atrophy, especially the medial temporal lobe atrophy. Hippocampus is the one where predominantly having atrophied, and find out the early signs. Alzheimer's dementia and control. PET scan is also found to find out the hypometabolism. You can see on the left side the red dot showing decreased hypometabolism. On the right hand side is a normal one. So what are biomarkers? Biomarkers is something you can take it out from the blood or CSF to find out early dementia. Amyloid beta imaging has been approved by the US FDA to find out to detect early dementia. Screening. So diagnosing ultimate dementia is essentially a clinical diagnosis. These laboratory are only supportive. The MRI and the PET scan clinical assessment is very crucial. Several clinical trials are in progress examining, but one such a technique is a beta, amyloid beta brain imaging technique has been licensed and has been useful. Tau PET is also underway. Biomarkers in CSF and blood, retinal screening technique like OCT, optical coherence technique, and then angiography. Definitive diagnosis of Alzheimer's dementia in earliest and most treatable stage is the usefulness of the biomarker, but we are yet to find out that biomarker. But amyloid beta screening can be seen up to 20 years before the cognitive symptoms appear. So any disease modification drugs will be really useful for these patients because the disease process or course can be completely altered. So how do you prevent the dementia to happen? A good physical activity, uninterrupted sleep for 7 hours every day. That's not possible with the doctors, but I think that's what we need to have when we cross the age of 50. Education and mental stimulation, doing a crosswords and Sudoku. Healthy diet, Mediterranean diet is one such a diet. Social engagement, frequent gatherings, frequently attending social gatherings. Stress management. And the comorbid factors like diabetes and hypertension and obesity and physical activity, simple physical exercise, 45 minutes walking for 2 or 3 times in a week is sufficient. Social engagement is also very good. So the risk factors is you should keep the cholesterol at the low level. Weight has to be reduced because obesity is also one of the modifiable risk factors for dementia. Drinking in moderation, but not in excess. Drinking should be recommended. It should be at the recommended level. Not smoking, eating a healthy and balanced diet, controlling a high blood pressure, controlling your blood glucose, physical activities. Traumatic brain injury is also a potential risk factor to develop a dementia, advancing age, genetics, positive family history, depression, and cardiovascular risk factors like smoking, obesity, diabetes, and hypertension. These are all preventable or modifiable risk factors. Cognitive engagement, social engagement, stress reduction, nutrition, and exercise. So the pathology is very, very important. 3 common terminology we all come across. It's one is tau, protein, amyloid, and then neurofibrillary tangles that causes a neurodegeneration following inflammation. Extracellular amyloid plaque and intraneural neurofibrillary tangles composed of tau proteins. These are the 2 major pathological abnormalities in the Alzheimer's dementia. There are several theories that has been brought out. The precise mechanism of the Alzheimer's dementia progression is so unclear. There is a cholinergic theory indicating decreased or loss of cholinergic neurons in the brain, causing the dementia, accumulation of the amyloid and tau protein, forming a neurofibrillary tangles deposited in the various parts of the brain, most likely explanation for the Alzheimer's dementia. Amyloid cascade hypothesis. The beta amyloid is the main component of amyloid plaque. Detailed understanding how the protein fragment is clipped from its parent compound, amyloid precursor protein, that's called APP molecule. There are 2 enzymes, beta secretase and gamma secretase. Why am I emphasizing? Because there are some trials has been tried to potentially inhibit these enzymes so that the amyloid precursor protein will not be deposited. A-beta amyloid beta cascade hypothesis postulated that after amyloid plaques are deposited, a cascade cause. It causes undue inflammation and then formation of the neurofibrillary tangles, with a very hallmark of the Alzheimer's disease. We know that the tau also accumulates in the medial temporal lobes of the brain during the normal aging. Tau does not extend beyond the medial temporal lobe until the amyloid beta is present in the cortex. So combination of the deposition of amyloid beta protein and the tau that causes the neurofibrillary tangles causes extensive damage to the brain and its cortex. So Alzheimer's disease research, they're focusing on the treatment aspect, the drugs and non-pharmacological therapies, preventive aspect, epidemiological and risk factors, genetics, and also the biomarkers. So generally, you know how to take a new drug, to market a new drug, how long it's going to take. It takes several hours for a drug to be come into the market. Before in the pre-marketing survey, and then first of all, candidate drugs has to be identified, and then it takes about 3 to 6 years to find out this drug potentially can work, and then preclinical testing in animal trials, and then it comes into the primate or human trials, phase 1, phase 2, phase 3. The phase 1 is like a pilot study, just do a few patients, and then taking on to a phase 3 trials, about 1,000 to 5,000 patients needed, and then you submit to the FDA, Food and Licensing Authority of the UK, US, and then finally it's marketed and the marketed post-marketing surveillance. So as I told you, it takes many, many years for a new drug to develop in the phase 1, phase 2, phase 3, and phase 4. Finally, it has come to that. Now we are coming to the treatment of the Alzheimer's dementia. There is no currently cure for Alzheimer's dementia. But what are all the medications which are available? The cholinesterase inhibitors like donepezil, which we commonly use, galantamine, rimanil, and risadin. Rivastigmine means anticholinergic drugs, increases the cholinergic destruction. increasing acetylcholine in the brain. The common side effects includes diarrhea and vomiting because they all have a cholinergic stimulation, which increases the bowel movement so that they cause diarrhea and vomiting and increase secretions. Memantine is the first drug approved to treat those in moderate to severe stages, and the side effects include the dizziness, an increase in agitation and delusion in some people. So coming back to that, what are the current medications which are available? The first drug has been developed is the anticholinergic esterase inhibitors, the donepezil, available as Aricept or Aricept, and then followed by galantamine, rivastigmine, and memantine. No new drug has been marketed, approved by the FDA for the past 20 years. The lack of understanding how exactly the pathophysiology of the Alzheimer's disease happens to find a treatment. So what are all the various other modalities? The immunotherapy, which has been hyped up in the media and also recently approved. So beta amyloid protein, good antibody response, anti-amyloid immunotherapy has been trialed in a few years ago, but unfortunately the trial has to be prematurely stopped because of significant complications in 6 to 7% of the patients. They developed in Edinburgh and then they had to stop because of the brain meningoencephalitis happened in few patients. So anti-amyloid beta therapy has not been useful. Alternative to actively immunizing the alpha amyloid beta is a passive immunization, bypasses the need to respond to an antigen. Passive immunotherapy leading to approach today activities today for the disease is a modifying treatments. Monoclonal antibodies is a large hype, and then one monoclonal antibody has been recently licensed in the Alzheimer's dementia. Several monoclonal antibodies have been studied, and some of them have been stopped. The one such antibodies is called monoclonal antibodies, bapineuzumab and gantenerumab, stopped prematurely due to the lack of perceived efficacy. Subgroups also did show some benefits, but unfortunately they are not eligible for the first FDA approval. Lack of efficacy that will be due to underdosing. Recently restarted these monoclonal antibodies. One such a monoclonal antibody has been licensed by the FDA is aducanumab. Aducanumab has been licensed by the FDA and American authority. It's also going to be recently soon launched in India also. That aducanumab in early stages of dementia found to be useful and delays the disease progress for the few years. So solanezumab, aducanumab, crinecerfont, aducanumab has already been licensed, but other solanezumab, crinecerfont, the trials are going and they are waiting for that one. So further approach is to reduce the amount of amyloid in the brain to reduce the production. Inhibiting the enzyme that help reduce the amyloid beta proteins means less is produced. There is an inhibitors called base inhibitors, specifically inhibit the beta secretase enzyme in the amyloid cascade so that the amyloid formation will not be formed or decreased. There are a number of studies in the progress looking at the benefits of the base inhibition in the mild form of Alzheimer's dementia. Other drugs which inhibits the gamma secretase, the other main enzyme involved in amyloid beta production, is unfortunately they do have unwanted side effects, quite significant one called skin cancer of the dermatological cancers and hair discoloration. So Semaglutide showed a promise in early trials but failed to show benefit in phase 3 trials. Two other gamma secretase inhibitors also failed to show the benefit. Scientists are still developing more highly selective gamma secretase inhibitors with less side effects and more effective inhibition of the amyloid beta production. Very interesting thing is curcumin. Curcumin is our spice, turmeric, manjal. It's an anti-oxidant and anti-inflammatory and anti-aggregation properties. It binds with the amyloid beta and reduces amyloid plaque and the burden in the animal models, but unfortunately it's not can be transferable to the human model in a large and randomized trial. It's failed to prove it. So limited studies in Alzheimer's dementia patients who are failed to show any benefit clinically by using the curcumin. So any drugs which is affecting the tau protein, far few drugs have been identified against the tau protein. Mouse and primate models show amyloid plaques that respond to anti-amyloid therapy, but no tau pathology like human Alzheimer's dementia. So treatment of these animals with anti-amyloid beta therapies, which I showed earlier, either by immunization or monoclonal antibody, reduces the plaque load, but no change in cognition or tau pathology. There is a very robust correlation between the tau pathology and the clinical course of dementia. When the tau pathology is reduced, the dementia impact is also reduced. Methylene blue, another drug which has been targeted against the tau protein, derived from the dye used for the neurofilament tangles in neuropathological studies. Phase 3 trials unfortunately, there has to be a 30% drop in because of significant side effects. The second generation compound is on the way, and it's going through on the phase 3 trials. Other top therapy, there are several drugs which inhibit the development of the top, has been identified and studied. Observation studies in geriatric patients taking a chronic lithium for bipolar affective disorder were found to have a decreased risk of developing Alzheimer's dementia. But lithium inhibits the chemical changes in tau protein, but that causes the formation of neurofilamentary tangles. The studies of the lithium in the trials have been mixed. There are no positive conclusion could be reached by this one. Tau immunization has been studied in the animal model, but the initial reports are no serious adverse effects, but they are all in the initial phase 1, phase 2 studies. They are yet to come across. Neurotransmitter receptors has been identified. 5-hydroxytryptamine. 5-hydroxytryptamine is nothing but a serotonin. Serotonin receptor blockage is a promising drug treatment for Alzheimer's dementia, but they are all in the initial studies, ongoing studies at the lower doses giving effect, but we yet to know about the results. So we all know that finally the neurofibrillary tangles produces a subsequent sufficient inflammation and significant inflammation, which causes a destroying of the neuronal death. So anti-inflammatory might should work. There are several trials using the anti-inflammatory drugs like naproxen, selexabat. Selexabat is a COX-2 inhibitor, which are all tried. But unfortunately, the NSA are not considered as a treatment practical options for Alzheimer's dementia because of the side effects, potential side effects like kidney damage and increasing cardiac and cerebrovascular events in all these patients. So the anti-inflammatory therapy, which are all negative, the trial is proven to be not useful. Anavex 273 media was which hype in the last years, sigma-1 receptors involved in the multiple cellular pathways and physiological process. 32 patients, 52-week study, mild to moderate Alzheimer's dementia, improvements in some form of psychomotor function, attention, and working memory. Its memory trials is going on. The results are not yet out to conclude about the Anavex. Vitamins and antioxidants, we all take vitamin supplements or prescribe vitamin B12 and folate especially. Unfortunately, there has been no sufficient evidence that low levels of vitamin B12 and folic acid linked to the Alzheimer's dementia. But in 2014, a group of Oxford University researchers assembled the best clinical trial data involving 22,000 of people who conducted taking vitamin B12 and folate does not slow the mental decline as we age, are likely to prevent the Alzheimer's dementia. So basically, there is no evidence-based medicine to prescribe vitamin B12 or folic acid in Alzheimer's dementia patient. Another common drug which has been prescribed is a vitamin D. Vitamin D has been primarily functions in the bone and metabolism in all of us. Not clear whether the vitamin D sufficiency is causally related to cognition. Early laboratory evidence of the vitamin B receptors may help regulate the clearance of amyloid beta protein from the brain. No firm scientific evidence has been found so far. Antioxidants, vitamin E, C, and beta carotene, all powerful antioxidants. Again, we prescribe a lot in dementia patients. Multiple clinical trials provide evidence that supplements with these components did not alter the long-term cognitive outcome or in the minimal cognitive impairment or Alzheimer's dementia in healthy elderly, but results are still debated. Ginkgo biloba, the Korean extract from the herbal molecules, suggested it improves the cognitive impairments, especially in the minimal cognitive impairment patients. There is certainly firm evidence that it does not alter the risk of dementia or improve the cognitive performance. Potential side effects could be bleeding tendency or drug interaction. Fish oil, omega-3 fatty acids, again thought to be neuroprotective. Unfortunately, studies have failed to confirm that any improvement in the cognition in Alzheimer's dementia. Large-scale studies are needed. Mediterranean diet, which includes the large olive oil, legumes, and whole grains and fishes, so the people live longer without any significant cognitive decline. That's a Mediterranean diet definitely shows a slow cognitive decline in older adults, reduce the risk of minimal cognitive impairment in progressing to Alzheimer's dementia, slow the progression of Alzheimer's dementia, and prevent the disease-related deaths. So diet plays a very crucial role. Mediterranean diet, a DASH diet, MIND diet, combination of various plant-based foods. The dietitian should know a little bit more about all these things. So the diet does have a definitive role, especially the Mediterranean diet and then healthy diet. More studies are needed to know what degree of this diet prevents Alzheimer's dementia and slows the cognitive decline. Suvanide medical nutrition supplements specifically for mild Alzheimer's dementia, which includes the omega-3 polyunsaturated fatty acids, uridine monophosphate, and choline and beta vitamins, B vitamins, and a range of other nutrients. It does seems to be delay the shrinkage of the temporal lobe and the hippocampus, but not evidence-based. Brain training, this is a quite broad and can induce range of structurally, mentally stimulating activities in addition to the physical exercise. Learning a new language, reading a book, undertaking further education, combining mental and social and physical activity, including the leisure activities, are the best for reducing dementia risk. Can intensive computerized training loop stop progressive cognitive decline and onset of dementia of ongoing aging process? Physical activity is again and again is crucial and important. The potential for physical exercise, especially yoga and meditation. People who exercise regularly are less likely to have vascular disease, which is a potential risk for Alzheimer's dementia. Physical activity is very, very beneficial, helps prevent the muscle weakness, mobility problems, and other health complications associated with inactivity. Also helps to reduce the symptoms of stress and anxiety and depression. 3 types of exercise has been prescribed. One is the aerobic exercise, weight training, flexibility, and the balance training is very important. Exercise program is incorporated in early stages of dementia, more likely to slow the disease progress, and full-blown dementia can be completely normal. Regular aerobic exercise confers the most benefit for delaying the cognitive decline and slowing the brain atrophy. Insulin resistance, indicating that the brain process may be linked to the Alzheimer's dementia. Researchers are exploring this avenue, but bioglitazone can be tried, and then it's on the trial, but early trial does not proving any promising incidents support to say that the significant cognitive decline when the patients are taking the bioglitazone. The study is ongoing and we'll wait for the results. Vascular disease and Alzheimer's dementia, and the hypertension, heart disease, smoking, high cholesterol, obesity, previous stroke, and diabetes, they are significant risk factors for Alzheimer's dementia. The relationship between the vascular dementia and Alzheimer's disease is complex and not fully understood, but I feel in some of the patients, they do have a overlap of the dementia and also the vascular dementia. One could potentially reduce the risk factors so that the delay in development of Alzheimer's disease. Research in familial Alzheimer's dementia, the 3 known mutation causes of familial autosomal dominant dementia, which is account for less than 5% of the dementia cases. Some of the rare genetic mutation, strong family history, will give us more insight into whether the treatment at the asymptomatic stage will prevent the development of the Alzheimer's dementia is very crucial. The prevention initiative, family carry the presenile mutation, affects the amyloid processing. The Alzheimer's Prevention Initiative is a performing study on asymptomatic individuals that carry the presenile mutation to see whether they can prevent any Alzheimer's dementia, which is going to happen. Dominantly inherited Alzheimer's network is also available, so you can join and get the information in the web. So outlook, often there are no simpler, complex solutions to Alzheimer's dementia. There is no simple solution to a complex problem like Alzheimer's dementia. Clinical trials are undergoing, but unfortunately disappointing, exposing several drugs which has not been fruitful in the clinical trials and data. In the future, Alzheimer's disease or Alzheimer's dementia can be treated like another chronic disease with mixture of disease-modifying and symptomatic therapies used in combination in sequence. Limitation will be adverse effects and affordability because some of the drugs are, especially the monoclonal antibodies, are very, very expensive. Although there have been many obstacles and setbacks and a long way to develop the treatment of Alzheimer's dementia, the future is still promising. We are hopeful that an effective treatment will become available in the near future. Trials of several promising agents are in progress here and also internationally. One such a drug is called aducanumab. Roche, Merck, and Amaranth is the forerunners in this process. Some of the other symptoms, how we treat the behavioral problems, monitor the personal comfort, simply communication. Person's attention can be increased, provide a security object, acknowledge the time, alarm time, and then the wristwatch, which contains a personal identification, so that if they get lost, it can be traced and found out by the police or the traffic wardens. Behavioral symptoms can be coexisting in Alzheimer's dementia, which can be difficult to control. They might need antipsychotic drugs or psychiatrist help, and sometimes when they develop a mania or psychosis. So what could be the active and management of Alzheimer's disease? Appropriate use of available treatment now so far, effective management of coexisting condition, especially the risk factors, obesity, hypertension, diabetes, alcohol, and smoking. Providing a family caregivers with effective training and management, coordination of care among the physicians and the other carers, participation in the activities that are meaningful to the individual with dementia, having opportunities to connect with other healthcare workers and also others such a group. From becoming educated about the disease is very, very important, because they do have a unrealistic expectation at the onset. If we could tell them that the disease is going to progress slowly over a period of many years, many of them will understand. So to conclude, lower education was associated with greater risk for dementia. So educate them early. Level of education is very, very important. When the level of education is higher, the risk of dementia is very, very low. High level of education in early life is related with a significant reduction in cognitive decline. Cognitive reserve hypothesis postulates that early stimulation, education, active management, regular participation in stimulating activities significantly lower the risk of dementia. Dementia is a common and neurodegenerative disorder in elderly. Alzheimer's dementia is the most commonest form of all dementia. Unfortunately, it does have a huge socio-economic burden and healthcare cost. Comprehensive care is still lacking in India and other developing countries comparing to the Western standards. Unfortunately, very few drugs are available to delay the progression. One such a drug is called monoclonal antibody, aducanumab, which has been licensed. Many thanks for your patient listening. Thank you.
Thank you, Dr. Arul Selvan, sir. We will be having our the panel discussion, and now we will have 5 questions from the Dr. Arul Selvan's talk. In between, it will be asked, and I invite all the people to answer it in the chat box itself immediately. Those who are telling the correct answers will be awarded. At the end of the program, we will be doing it. In between, we will be asking 5 questions totally. So first, we will have the first question today. Naveen, are you ready?
Yes, sir. We are starting.
Monoclonal antibody approved by FDA recently. Okay, Naveen. Now you put the introduction about Dr. Sridevi madam and Dr. Ganesan sir. Now we have our panelists today. Now we have our panelists, Dr. Ganeswaran sir and Dr. Sridevi madam. Naveen?
Yes, sir. Yes, sir. 1 second.
Yes. Thank you, Dr.
Here we have now Dr. M. Sridevi is a consultant neurosurgeon, Royal Care Super Specialty Hospital in Coimbatore in the city unit. Completed the MBBS and MS from Coimbatore Medical College and MCH from the Madras Medical College. And she was the consultant neurosurgeon in KG Hospital, Coimbatore, 2001 to 2016. And since 2016, working as a consultant neurosurgeon at Royal Care Super Specialty Hospital. As a co-author, written articles on angiosarcoma skull bone presentation, subdural hematoma, the Journal of Neurosurgery, trained in doing percutaneous trigeminal ganglion balloon compression, decompression, trigeminal neuralgia. We invite our next panelist, Dr. R.A. Ganeswaran sir, Preeti Hospital, Erode. He is a senior consultant neurophysician practicing in Erode. MBBS from Tanjore Medical College and MD from the Tanjore Medical College. And in 1995, he was DM Neurology from the Madras Medical College, Chennai. And 27 years he is doing senior consultancy in Sri Preeti Hospital in Erode, and special interest is epilepsy and stroke. I invite Dr. Sridevi madam and Dr. Ganeswaran sir. And another panelist is not feeling well. That's why I have not introduced. That is Dr. Aruna Devi madam. She is a consultant neurophysician at GKNM Hospital at Coimbatore. Now we will have the panel discussions. The panelists also can take over.
Thank you. Dr. Devigan sir, Dr. Lakshmi Narayanan, all those things. Welcome, sir. Sir, you can unmute, sir, please.
Since Dr. Devigan sir is our senior professor from our institute, I request Dr. Devigan sir to give his experience about.
I got actually two cases which I like to tell to you. One was my classmate's wife, who was diagnosed as dementia, was being treated at various places. Finally, she landed up at a corporate hospital in Chennai, where they found out that she has got multi-infarct dementia and she had a carotid artery stenosis. She underwent an ECMC bypass and she completely became normal. And very recently, I saw a patient who was being treated as a dementia by a physician. Later on, she met a psychiatrist. She was giving some drugs. Then she went and met a neurosurgeon who did a scan. See, for nearly 2 months, no one did a CT scan or an MRI for the patient. And finally, it was found to have actually, unfortunately, GBM, which was infiltrating much into the frontal lobe, which has caused features of dementia. So, I always think that all dementias are curable, because most of the non-surgical causes of dementia, they don't really improve very well. That is my first take on dementia.
Excellent, sir. Excellent. I think we really re-emphasize, prove that you are an excellent clinician and a teacher as before. As treatable dementia should be the first focus when any patient comes to a clinic to find out, starting off with a simple blood test like thyroid. They might have told, we have done that, sir, we have done that, but we still insist that we do the simple blood test because potentially these dementias could be treatable. Neuroimaging, anything is very, very crucial to rule out all the causes of dementia, as you correctly say. Normal pressure hydrocephalus or hydrocephalus, third ventricular tumors, temporal lobe SOLs, or frontal lobe tumors, butterfly gliomas, and then chronic subdural hematomas, my case has shown. So we further emphasize your point, sir. That's very, very valid. We really undertake that it's very important for a young generation of neurosurgeons, neurologists to find out, dig out the causes which could potentially be treatable.
But mainly, most of these patients go to general practitioners or physicians. Because they are the people who should be really highlighted about all these issues. Actually, today I learned from you that hypothyroidism and decreased vitamin B12.
That is one of the common.
Yeah.
Good evening to all, and madam. Yes.
As Dr. Devigan sir said, and Dr. Arul Selvan sir also emphasized that first we must see the treatable causes of dementia, which are curable by surgical techniques, like NPH, and tumors like frontal and temporal lobe tumors, chronic subdural hematomas. And most of the time, these dementia patients first see the physicians only, general physicians or neurologist, and then only come to neurosurgeons. So there are very few causes of surgically treatable dementias, and they are curable.
First of all, I want to tell certain important points. First, most important thing is all memory disturbance. All memory disturbance are not dementias, first of all. And most of the time, if you brand a patient is having dementia, especially Alzheimer's disease, and there is no specific treatment, there is no curative treatment, and what we give is mostly conservative treatment and caregivers. So first and foremost, most important thing is creating awareness among the general practitioners, physicians, surgeons, etc. With the availability of CT scans and MRIs in nook and corner of Tamil Nadu as well as in India, I think these surgical causes like chronic SDH and normal pressure hydrocephalus, tumors, trauma, multiple cerebral infarcts, and these things are very easy to diagnose. The medical causes, especially vitamin deficiencies, pure vegan vitamin deficiencies, hypothyroidism. We have seen many patients with hypothyroidism initially present with the dementia, as well as giddiness. And vertigo is very common, one of the common causes of, one of the commonest symptoms of hypothyroidism apart from other symptoms. So those things has to be thought of. Then of course, any drugs, any anticholinergic drugs they are taking, which has to be anticholinergic drugs, whether taking any anticholinergic, we have to get the drug history and diet history. And the most important thing is depression. Depression is very common, one of the commonest cause of pseudo dementia, because most of the depression is very common, more than what is estimated in the society, especially with the what is called with IT people and other things. The depression is more common, and alcoholism is also more common. So we go to rule out all those things. Medical causes, ruling out the medical cause, because surgical causes is very easy. If you take a CT scan, chronic SDH and tumors, it can easily diagnose. But medical causes we have to think of, we have to rule out a chronic liver disease. If a slowly progressive liver disease can initially present with dementia, we have seen quite a number of patients. Renal disease also slowly progressive, initially they present. So sensitizing the practitioners, especially MBBS doctors, about what is dementia, what is commonest memory disturbance, and generally the mini-mental state is very easy to apply, and easily it can be taught to the duty doctors itself, so that they can apply and then they can screen the cases. And even the non-medical people we need not have a neuropsychologist to diagnose a dementia. We can train our people. A BSc physics, BSc people is enough to get trained with all those things. So first of all, sensitizing the people, diagnosing the medical causes of dementia, these things are very important. The role of physician, role of doctors comes in the early stages of dementia, whatever the cause, Alzheimer's disease or whatever cause. The moderate and severe case of dementia, the main role is family members and caregivers. Because our awareness about stroke, epilepsy is more when compared to dementia. So even Alzheimer's disease awareness is more common in Western people than our people. Nowadays, the people are coming with the memory disturbance and other things for consultation. So the family members and caregivers has to be given for moderate and severe dementia, especially how to take care of their personal hygiene, how to manage the agitation, how to manage the aggressiveness, how to manage the mood swings, etc. I have personally had relative of dementia. It's very difficult in moderate and severe cases unless some pointed care or any focused care is there. I think like epilepsy, we have to train these people. What Dr. Arul Selvan, madam?
I agree, and a very valid point, but like Western country, they do have nursing homes, which means these dementia patients will be taken in, and then they'll have almost like jail, but it's very guarded.
Got
So
it.
you cannot enter without your fingerprint go into that patient,
Mm.
and then the patient cannot come out. The carers will be allowed only on the visiting time, and then in the evening. But the cost of care will be really very high.
In our country,
Secured-
even taking care of stroke patients is difficult. Suppose a
Yeah.
patient has Ryle's tube, one patient has got a weakness, residual weakness, we find very difficult to take care. Nowadays, people is okay. They are having home nurse and then managing. I think the nursing curriculum they can include how to take care of these people, and mainly the family members. The family members are sensitized because you should not keep the things regularly. You have to keep all the things in order. You have to keep whatever we take person, whatever we take, we should keep in correct order, correct place, so that and most of the time these people should not be allowed to go out. They may lose the way to home, and we have seen quite a number of patients who roam around without finding where the house is, and they have difficulty in managing the money. If you give the money, they will not get the correct change. So these things are the probably people who are ambulant. At the same time, they will have difficulty. Suppose patient is bedridden, it's okay. Caregiver is going to give it. Those who are this middle stage, they are ambulant, but they will not accept their problems. And family members also will not accept they got a problems. So sensitizing these people is more important. I think it needs a very big effort, because nowadays only even epilepsy people are now coming out. Previously they will not come out for the stigma is associated with epilepsy. Now I think they are coming out with epilepsy and stroke and all. I think it's a long way to go in our country.
I have a small question. Normally, you never admit any case of dementia in the neurology work, okay?
Yes.
As I have seen in the past 30 years, okay? Then how do you think the nurses will get trained in managing dementia patients? Unless you have a separate...
Sir, it's
Yeah.
not the... it's very simple how to... That is simple giving care for a normal patients. Giving care for a normal patients. How to... because they will not follow the advice. They will not follow the advice. And just giving personal care, giving medicine in the proper time, and keeping things in order. Likewise, it's just like normal nursing only. Normal nursing only. Need not get admitted in the ward.
No. That is for early stage, okay? What Arul Selvan told you, where you put in a fingerprint and then only you can enter, you can never come out. Those are the later stages of dementia where
it's not in is it available, Arul Selvan? Is it available in our place? This type of arrangements?
I think it's Coimbatore started the dementia care for nursing home. I don't think it's fully available as like in Western countries. UK has been the majority of the dementias are undertaken by the care has been undertaken by the psychiatrist.
Even here it is being done.
Even here as because they come with mood and personality changes, and CT scan is taken by a physician or MBBS doctor. If the CT scan report a normal or mild cortical atrophy, it is referred as a psychiatric complaint, and they refer to psychiatric patients. That's why most of dementias are taken care. Moreover, there is an overlap. We cannot call it's pure neurological, pure psychiatric, because both are co-brothers, no? Psychiatric, neurology cannot be.
That's wonderful. But what I'm telling you is, don't you think the IAN should take the lead in in developing dementia care centers, just like they are taking care of developing stroke care centers?
Definitely, sir. The problem is the burden of dementia when compared to stroke, epilepsy, and other things is relatively less. And the stroke is potentially treatable, and it affects in an age where the person is active, middle-aged, because once we are studying MBBS or MD, we see stroke only after age of 55 or 60. Hope Dr. Arul Selvan remember. Now we are seeing stroke at the 45, 40, 45. Young strokes are becoming more and more common. So the burden of stroke, epilepsy, and is more when compared to dementia. And there is a separate subsection of cognitive neurology in IAN, and they are taking care. I think in years to come, in suppose 3, 4, 5 years, I think these things will also come to the surface, and these things will also be given important. Like interventional neurology, people, interventional neurology, movement disorders, stroke, epilepsy. These are the 4 major areas where the neurologists are concentrating. I think this also, as you told, Ian is also taking interest, and I think they will take care. We will also project your ideas.
Probably before we get demented.
No, you are very active at this stage. And moreover, what we read is one thing is I can tell you is for all youngsters, we go to at least to our house as well as to our friends. First of all, we should have a regular lifestyle. Lifestyle modification is more important to prevent, at least to prevent or postpone the dementia. First is this. I think this cell phone, this smartphone has given a lot of memory disturbance. Previously, we used to remember about 200 phone numbers easily. Now we remember only our wife or brother or son remember. Other numbers we don't remember. That's one of the handicap of this phone number. So learning new techniques, playing chess or playing Sudoku or something, or learning new techniques or reading regularly. This is very important. We don't read regularly now. We don't read regularly. Then, of course, taking food. Nowadays, this food is more of fast food. We should take more green vegetables is more important. And then taking nuts is most important, especially walnut. They say this is very good for brain health.
Sorry, could you say that again?
Walnut is very important for brain health, and taking nuts and avoiding alcohol. These 3 things important for youngsters. And most important is sleep, because nowadays this, especially for IT people, the sleep deprivation is very common. Especially the nightlife. They go to nightlife, they don't sleep properly. And about previously, about 9 o'clock, 10 o'clock, people go for sleep. They will get up early hours. Those things are very good for health. But nowadays, people get sleep very limited, only for not even 5 hours, and working in very odd hours. And they don't follow the cognitive, they don't follow the diurnal rhythm also. So sleep is important. Proper sleep is important. And exercise is more important. If you do proper exercise, walking or whatever it may be, at least 3 days per week, aerobic exercise, not necessarily for other, we need not go for a special coach or trainee. Those things, if we follow the lifestyle modification, I think we can postpone the onset of dementia. If at all, because branding a patient has got a dementia, especially Alzheimer dementia, we are giving what is called like
Life sentence.
oil sentence, exactly. And there is no, even sometimes we can say it's a death sentence, like 10 years or 15 years, it has to be executed. So as you told that treatable causes has to be considered. Yes, Dr. Sridevi, madam.
Sir, now we will go for the second question, sir.
1 minute, can I just ask one question for Dr. Arul Selvan? Sir, what about this new Neurolink and some chip implant and all those things? Elon Musk is planning for the thing in the recent advances for Alzheimer's.
Yeah, it is all recently developed, including the artificial intelligence putting in the chip, but they're all in the only experimental model. So not all the experimental model turns out to be very fruitful when it comes to the clinical trial. Like many drugs, we need to wait for their results. It is possible they could subcutaneously implant the chip into the forearm, and then they get the neural networks activation could be potentially happening along with the artificial intelligence. But it's too early to conclude anything about that. But we need to wait for their results or their early success, I should say. It's a potentially explorable possibilities, potentially welcoming possibilities. So we need to wait for their at least the release of the to the public domain what they have done and how many patients, and we are still not sure about that.
But actually now we are getting all the radio advertisements for the recruitment.
Yes,
And
yes.
I don't know where it's going.
No, when it comes like the amyloid beta protein anti-immunization, like a vaccine, the vaccine was developed against an amyloid beta plaque, and then subcutaneously it was injected into the volunteers. And then initially the animal experimental studies were positive. The amyloid beta deposition was very less in the immunized animals, the rats. So, and also they have done in the monkeys also. But when it's done in the human beings, they developed a meningoencephalitis. So the trial has to be abruptly stopped. I remember there was one patient died in Edinburgh, so they had to pay a huge compensation. So everyone is reluctant to do that nowadays. So that's why there was a sudden stoppage of the trials for a few years before the monoclonal antibodies have been reintroduced.
Arul, I got two questions to ask. How common this Alzheimer disease in our clinical practice? How common?
Sir, how common? I'm not sure.
Just is not an accurate statistics. I don't want. I just
probably about less than 5% in our practice. If I see 100 patients, probably 2 or 3 will be dementia patients.
Alzheimer's I'm asking, not the general dementia.
Alzheimer's dementia will be less than 1%.
1%, yeah. Is it, but they say this, what is called, this PET scan, no? FDG PET, and another PET is there, no? Pardon?
SPECT scan.
PET scan.
FDG glucose PET.
FDG PET, there is another PET called amyloid PET. Amyloid PET, is it available in our country?
No,
they say amyloid PET is more sensitive and it can detect the amyloid.
That's what I said in my lecture, the amyloid beta neuroimaging technique, amyloid beta PET technique.
Is it available in our country?
Not yet available. It's available in US and UK.
Yes, there it's available.
There it's available.
UK is available.
Yeah, if the patients have potential, for example, they have a strong family history of Alzheimer's dementia and pre-senile mutation is positive, they are eligible.
I think you can install in Royal Care Speciality.
And yeah, all the
because people are pioneering installing all this ultrasound and other things. These things also for medical people, no? For medical, I think you can introduce, no? Okay, in a lighter vein.
There are 3 or 4 questions in the chat box by the participants. If you could answer, the panelists, if you could answer that, that would be good, you know.
Sir, before that, Dr. Rajesh Babu wanted to do the second question because the price is...
No, it has been put and answered there.
Yeah.
Second question has been put there already.
Oh.
And a lot of people have sent the answer, yeah.
Okay.
Now, 2 questions I remember. One question was, will taking tea and coffee produce dementia? That was one question. Okay. Taking
no, it
lot of
will
tea
not cause dementia, sir. Caffeine is a potential stimulant. So it's not cause any dementia. So they can drink plenty of coffee.
That was one question which I saw. The second question just now I saw. What is the incidence of dementia in diabetes?
We don't know the exactly subgroup how common, but generally the comorbid factors as we consider dementia, diabetes is one of the 4 most common because it's not only the diabetes, they come with a vascular disease. Diabetes is increased risk for stroke. Diabetes increased risk for aging process. Diabetes is increased risk for microangiopathy. So being a diabetic itself is more prone to develop dementia. Whether it's a vascular dementia or Alzheimer's dementia, doesn't matter. But they are potentially prone because of the microischemia, microangiopathy complications.
Do we have any statistics of what is the percentage of diabetics who develop dementia?
I'm not sure, sir. I don't have on my top of my head. I'm sorry.
Yeah, fine. Because we should give respect to all the participants. You know, they are so eagerly putting questions into the chat box.
There was one more question, sir. Any difference in the outcome of dementia treatment in the male and female?
That's a wonderful question. But we don't know the outcome of there is any significant difference between the male and female. The outcome is similar in the treatment respect, but generally we feel that the dementia is more common in women, especially the Alzheimer's dementia. So as far as we are concerned now, there is no significant treatment outcome other than in the sex.
Good. What about Suresh?
So now we will
experience
put
with
the third
dementia?
question, sir. Third question we will put, sir, now.
Yes.
1 minute. We will put the third question. Naveen, put the third question.
Rajesh Babu, another question has come. Role of DBS in dementia management.
Role of DPS.
Role of DBS,
one
deep
second.
brain stimulation.
Deep brain stimulation.
So we have heard about deep brain stimulation for dementia. There were some trials were going on in Liverpool and also in Oxford. They put that electrodes in the deep parts of the hippocampus, but unfortunately the success rates are not warranting that it's a part of the treatment. When we come out of the cognitive decline, there's no improvement, as you say that. So there is
They have to
no
be
clear
considered as
tool for
failure.
that. Yeah, it could be early stages, you can restrict and stimulate the hippocampus, but by the time they reach to a clinician, the disease process is spread beyond the hippocampus. They've gone into the thalamus, amygdala, medial hippocampus, temporal lobes, and also in the frontal and temporal lobes. So the neuronal networks and the damage is already significantly damaged, so it's gone beyond the temporal lobe. So that's why the results are not successful.
How rapid the dementia advances in later stages? 2 to 4 years, 1 to 3 years, 4 to 6 years, 1 to 5 years. Okay. Yes, we can continue.
What about Suresh Jayabalan's experience with dementia?
Sir,
Is he there or is he left?
No,
Okay.
yes, Dr. Arul Selvan first slide. Of course, I have some experience with the chronic subdural and some meningioma. Surprisingly, meningioma is present with the dementia. Psychiatrist has given us a case. Apart from that, nothing, sir. Only thing after listening to his talk, looks like I am having the dementia. All the
No,
symptoms.
all of us will be having. You have to
All of
forget
them will have
something.
this idea, no?
Yeah.
So one of the most important thing which Ganesh told, that is very important, that is you practice everything regularly, that keeping everything at one particular place, then taking it. You should practice like that. I still remember what my father used to say. He will keep the pen in the same place, pucks in the same place. Slight disturbance he will ask, because we go and search something, we disturb. Next day morning he will ask, who has opened the drawer? The pen is not found in that particular place, he will ask. It is like that. That discipline, you develop the discipline, probably dementia will not come so early, I think.
No, it is not so, sir. Dementia will come, but at least you can overcome that. That is what, because we used to practice regularly. What I feel is if we have to do different things, then only I think dementia will not come. Maybe the incidence will come down. If you do the same thing regularly, means maybe we hide the dementia. I don't know, the neurologist, Dr. Arul Selvan and Dr. Ganeshan sir can say.
You, as you said correctly, it can delay the process.
Progress.
At the age of 60, you learn something. For example, you learn dancing, you learn music, you learn singing, you learn guitar, you learn flute, something. So the dead or dormant neuronal networks will be reactivated. The neuronal rewiring will happen again. So So it will activate further neurons so that it will delay the process. Certainly been proven in the literature also. There are evidences that patients who have complex movements like dancing, swimming, cycling, certainly prevent neurodegenerative disorders, including Parkinson's disease.
Good. Arul, what about this donepezil and memantine? Whether it delays the progression of the disease or it treats only symptoms?
It does not treat only the symptoms because they are all developed against the symptomatic.
Is there any particular sign or any particular clinical things clue can tell us that some patients gets very fastly deteriorating, some people slowly they deteriorate. Is there anything available clinically?
Amyloid beta scan.
Only beta scan, it can tell us. Clinically,
how far the amyloid beta has been deposited,
deposited.
neurofibrillary tangles has been deposited in the brain. We can clearly prognosticate if they are deposited only to the temporal lobes, then they find they're going to live for next 10 years without any disturbances. But already been widespread deposits in some of the patients, then the prognosis is going to be guarded, and then expectancy of the life will going to be shortened.
Thank you, sir. On record, I think I have to congratulate and thank Dr. Arul Selvan that it has crossed 400 people online.
Oh, thank you.
It's a great
nice
thing in for a dance. It's one of the very few kind of lectures we crossed this, and thank you very much. It's in
one thing regarding the monoclonal antibodies. What is your experience, or how many patients you have done the treatment so far?
No,
and
not available in India.
Yeah?
It's not available yet in India. It needs to be launched.
Sir. Your experience, I am asking, sir. From your experience, how many patients you are till now you have started treating it, and how many patients have shown some improvement and good improvement also? So your experience about that, sir.
We have not personally treated any patients with aducanumab. It's available only in States, and recently it was launched in the UK. So I do not have any personal experience. But the patients who had a mild dementias are only eligible for this kind of treatment because it's enormously expensive. And the patients should have written conditions. They should be seen by a neurologist and psychiatrist, confirm the diagnosis of dementia, then only the drugs will be given. Because in National Health Service, it is free of cost. So you don't need to pay a penny. But in India, it's not yet launched. I'm sure it will be soon launched, and then we will share our personal experience.
What about L-carnitine and Alzheimer's disease? L-carnitine.
L-carnosine.
Madam, like many other molecules, these are all out of the labels, but we don't have any evidence-based trial to support that L-carnosine is delaying the treatment of Parkinson's disease. Alzheimer's dementia. So any patients who comes and claims pharmacy companies usually push this one delays, and I don't know where they got the evidence, but they have some kind of published literature. They will show it as 50% reduction in the cognitive improvement, and I don't know how far it's real. So personally, I don't believe those things. I'm not prescribing any L-carnitine to my patients.
Now we will put the fourth question, sir. Naveen. Most commonly prescribed drug in Alzheimer's dementia is? Okay. Sir, regarding the treatment centers, you were telling about these centers are available in the abroad. what have from your experience, and if you have gone there and seen the centers, how it is? I like to know some of the few points about that center. How they have separately like a hospital, or like a home, or like a counseling center.
Yeah, these centers are all called dementia cares, nursing homes. These are all developed by the government authorities. So you don't need to pay anything in the National Health Service if you are eligible for the dementia care. It is a purpose-built nursing home, probably about 60 to 70 rooms, and then common rooms like television room, like a hostel, television rooms, and each room will have their own restroom facilities, common dining hall, common television room, common playrooms, common worship prayers hall. It will all be common. Weekly, once or twice, a psychiatrist will come. Every day will be looked after by routine nurses and therapists. So these patients, they are given in addition to the medications. There will be, these are all patients who are mobile. Immobile, they cannot go into that nursing care. So they'll be taken for a picnic in the weekends. They'll be given daily activities like reading the newspapers, sudokus, occupation therapies, swimming sessions, dancing sessions, listening to the music, and then creating in activities like that. They will also be given in the food also on the same dining hall. They'll be given, each patient will be tagged so that they cannot go out. They can, all the sharp instruments and other things will be taken away from the patients, and they'll be not available for their use. So it's a wonderful service. I think we all need to develop in India also to learn from these services. Visitors are allowed morning and the evening, and then weekends, Sundays, they can all come and see their dad or mom. But it works as expensive. Probably it costs about 100,000 pounds per year for each patient. The government pay for it, so that's why it's been possible in the UK.
That we need to create some centers in our country, or we will start in our places also, sir. We should.
We have given lecture at Nana Nani, the old age homes. You remember that we have done few lectures in the Coimbatore.
Yes, sir.
Yes. So those are all the similar, but not for the dementia patients. So the principle is similar: community living, which includes a temple, common dining hall, playroom, washing room, and everything. But the patients can, the people can stay in their own flat or home or villa, but they don't need to do cooking, washing, or anything. It will be done by others. They'll be taken care. We know that there is an inside medical officer also, inside nurse also, 24 hours care for the medical emergencies. So, but from that principle, they need to evolve into carrying the dementia patients also.
Problem is financial constraints. Financial constraints. Even we don't have comprehensive rehabilitation center for stroke patients. Every district, at least, we should have some stroke rehabilitation center at least. There are many patients who are suffering stroke and injury. All patients who are left with residual deficits, they find very difficult. They find very difficult to get accommodated in the house, and they don't have. Basically, it's a socio-economic problem, and it has to be taken to the administrators and rulers. Unless they are very, they are acceptable, then only it will be possible in our place. Where in NIH it is different, I think. It's everything is taken by the government. All treatment is government free of cost, I think, isn't it? In the UK, it's free of cost. Here, the system is different. Both government and private, and insurance is not that much covered. Rehabilitation is even for treatment, people find difficult. Even for stroke, we have to sensitize people to come before 4 hours. There are a lot of patients, even doctors, MBBS doctors, they don't refer the stroke patients before within the time limit, within 4 o'clock, within 3 to 4 hours. They come, they give some injections, then ask them to go to the doctor only after 12 hours or 24 hours. our situation is like that. I think a long way to go to develop dementia cars and all. I think it will take a decade for development of those things. What, Dr. Arul?
Now, myself and Suresh, when we were working in UK, we could clearly remember when the acute care is over, the patient will be handed over to the rehabilitation, like geriatric services or geriatric ward. For example, they will do the subdural hematoma, evacuate. Once the patient is conscious and moving on the four limbs or moving without any significant deficit, the patient will be handed over to the rehabilitation, either neuro rehabilitation or geriatric rehabilitation. From then on, they will take care of those patients. So the acute care setting is really expensive because of the ICU care, drugs, round-the-clock doctor services, and other things. Once they go on into the rehabilitation services, the cost has drastically come down because the patients will be shifted to the neuro rehabilitation center, which will be outside the city, so that the cost will be less. They don't have a
The cost will be borne by the patient or the government?
No, of course it will be the government, but they also looking at
That's a problem. That's a problem. If here the situation is different. Here the situation, as you know, it's different. If it is going to be private, no, it's going to be private. I think nobody will be willing to hand over the patient to the rehabilitation center. Even they don't even refer the patient to higher centers for treatment for strokes, especially in full-blown strokes, leave alone TAS and other things. The investigations, everything is very undermined. It's not up to the mark, I think. If it is going to be only government where there is a system, I think those things, those handovering to the patient, the rehabilitation center and everything will be okay. Here the system is little different when compared to EK. That's the problem.
No, sir. In India, no, from the day I come here, I was requesting everybody to start a rehabilitation center, but nobody wants to. The problem is they don't get much money. That's one thing. The second thing is even the families don't want to go. The most of them, the head injuries, we try to send them back to their home or somewhere, teaching them the tracheostomy care, all those things. But still they don't want to go. They wanted to stay in the big hospital. You see, every day they wanted to spend rather than going back. That is also a problem in India because it's all individualized. It's not the system based. Individualized. If you have money, you spend it and you take care of it. If you don't have money, then that's a different issue. Like that, it's going on. Definitely, there must be some rehabilitation centers in each and every city, outside the city, where they can take care of it with the low cost. Definitely, it's better.
I think it should be more of government rehabilitation centers. I think it should be better because nowadays there are a lot of physiotherapists and other people are available. And government is constant. Now the CT scan is available in every center, and the healthcare delivery system is quite good in our place, in Tamil Nadu especially. I think this rehabilitation has to be taken care, and government should initiate, because the patient who comes to secondary level centers like ours and patient comes to tertiary centers to like yours is quite different in terms of economic conditions and other things. Is basically everything revolves around the economic conditions. As you told, if they have money, they stay in a big hospital and they stay whatever time they want. But those patients forms only very little percentage. The main chunk is divide of money. One group, very poor, they go only to government hospital. Another group, very rich, even for a small abrasion of the scalp, they come to corporates. And only the main chunk, the middle group, find very difficult where to go. Neither they find difficult to go. Now the insurance comes to little help for them, where to go. I think the government has to take care. Nowadays, the rehabilitation center is being started by many people in, I think, Arul, your classmate has started. It's going well. Dr. Kaja is doing well, I think. It started near Namakkal, and a few physiotherapists has come forward to start. As far as money is concerned, they get reasonable amount. They get reasonable because nowadays earning capacity is better, and people find difficult to take care of them in their house itself, especially rails feeding and other thing. They find difficult to take care of in the house. So they are ready to send them to rehabilitation center. And for low socioeconomic and low middle class people, I think the government has to start government hospital. They have to start the government rehabilitation center. I think our neurology group, at least we can start rehabilitation center in each district. Our IAN or like Coimbatore, can Coimbatore group, Neuro group can start a rehabilitation. Like we are planning after the conference, we are planning for a rehabilitation center in Erode also. Arul, after TANCON is over, we are planning for a rehabilitation center. So that it's a common center, so that people can benefit. This is also one in the card actually. Likewise, we should we can take some initiative and we can collect. We can put some corpus fund. We can also get funds from other people. I think like people have got a, we here in Europe, they got a center for tertiary cancer center. Likewise, neurologists and neurosurgeons, we should come forward and start rehabilitation center, comprehensive rehabilitation center. I think it will, there are many physiotherapists who are willing to work for a minimal salary, like a visit. And there are paramedical stops are available in plenty of things. I think we can engage them also. I think before government takes, and we neurologists and neurosurgeons and neuro groups should take some initiative to start rehabilitation center. It's what my idea.
Sir, now we will have the fifth question, sir. Fifth question. Recently advanced imaging technique in Alzheimer's diseases. Naveen. Actually, yeah, when I was in Erode, I started the Erode Neuro Foundation Trust.
Yeah.
That was the Neuro Trust was started. Actually, when I started that, I was thinking in terms of starting the rehabilitation center. That is the main aim of starting a association in Erode. That was the main aim. But unfortunately, I left Erode early. That is the main thing.
It's very unfortunate
once
that it's very unfortunate that a dynamic person like Rajesh Babu we are missing. His real words is not from, it's from heart rather than from mouth, and he is very instrumental and he is very proactive, and he will keep everyone active. The very fact that I'm very surprised to see that TANS is doing very well these meetings. I'm really surprised to see. So first time I'm joining this meeting. Really, congratulations to all TANS members, especially office bearers, Dr. Jayabalan, Dr. Suresh Jayabalan, Dr. Rajesh Babu. Congratulations.
The same way, then I went to Coimbatore. In Coimbatore, the Neuro Association was sleeping. So immediately what I did was, I have made everyone to be active by creating this Coimbatore Neurological Society. That is the main thing. And from that, we wanted to do this rehabilitation type of activities. With the help of our neurologists and neurosurgeons, we should be starting the rehab centers for dementia and stroke and all those things we should create. That is our main thing. And next agenda, we will be putting in that. That is the main thing I wanted to convey it to all. And even in Indian Medical Association also, we should be able to create an awareness and start the things like that, sir. That is the main thing. We should be stimulating our state leaders, and we should be creating like that. Only when we start doing it, the government will think and they will start doing it. That is the main thing, sir. Because only when so many things are done in a private and the government is seeing and starting the things, it is happening. That is the main thing, sir. So that's what I wanted to convey.
Definitely.
Suresh, sir, anything you want to tell?
It's okay. It's a nice meeting. I think it's a time for us to conclude.
Sir, 1 minute, I will
Anybody
tell the
wants
results,
to?
sir. Sir, I will tell the results, sir.
Yeah.
The winner for the first question is the Dr. Nagavishnu Shankar. The answers you put, Naveen, you put the answers. So the answer for the first question, monoclonal antibody approved by FDA recently is aducanumab. The answer was given first by Dr. Nagavishnu Shankar from Tirunelveli. Nagavishnu Shankar available? Congratulations, Nagavishnu Shankar. Then the second question. Which is the commonest form of dementia? Alzheimer's dementia is the answer. The winner is Dr. Suresh CP. Is available? Dr. Suresh CP? Dr. Suresh CP is the winner. And now, Suresh CP, can you
Yes,
come
sir.
into the screen? Suresh CP, you are from which place? Hello?
We need to unmute him, sir.
Naveen, unmute பண்ணுங்க CP Suresh. Nagavishnu Shankar unmute பண்ணுங்க.
Sir, Panta sir, and they can unmute sir.
You can unmute yourself and come out. Nagavishnu Shankar, unmute yourself and come.
Sir.
Nagavishnu Shankar.
Yes, sir.
Congratulations, Nagavishnu Shankar. Always
Thank
you
you,
are
sir.
winning at least one question or two questions sometimes. Congratulations.
Thank you, sir.
Now, Dr. CP Suresh. Dr. CP Suresh. Yes, Suresh, you can come. You can talk. Dr. Suresh is the DM Neurology PG. Huh? Congratulations. Now the third question. How rapid the dementia advances in late stage? 1 to 3 years answer. Dr. Kirtana is the winner. Dr. Kirtana is there? Dr. Kirtana. Dr. Kirtana. Now,
Yes sir, she is
Dr.
there. Sir.
Kirtana, can you talk? You are from which place? Dr. Kirtana, you unmute yourself and you talk.
Sir, from Hosur, sir.
You are, what is your
From
specialty,
Hosur, sir.
madam?
Sir,
Your specialty,
MBBS
madam?
always. MBBS, sir.
Oh, congratulations, congratulations.
Thank you, sir.
Okay. Now the fourth question is? Fourth. Most commonly prescribed drug in Alzheimer's dementia is? Donepezil is the answer, and the winner is Dr. TamilNadu. Dr. TamilNadu is available? Dr. TamilNadu? Okay, now the fifth question.
1 second sir.
Recently advanced imaging technique in Alzheimer's disease. The answer is beta amyloid imaging is the answer. The winner is Dr. CP Suresh. Once again, Dr. CP Suresh, the neurology PG from Salem. Congratulations for all the winners. Okay.
சார் என்ன பிரைஸ்
Sir, Dr. Saravanan Vedagiri, sir, is the INMC observer. Sir, you would like to tell something, sir?
Excellent talk by Dr. Arul Selvan. In fact, I came as a observer, but I listened the whole course of discussion. It was very good. It is new to me because I'm a general surgeon, and the neuro subject is really nice, interesting. Thank you very much, sir. Thanks for inviting me, and it's nice. Between 300 to 400 participants are given point of time. Almost 420 groups. It's very nice. I'm really astonished to see so much of participants in the Zoom meeting. Thank you very much, sir.
Yes, there is no formal vote of thanks. I like to thank everybody for your participations, and especially Dr. Arul Selvan for his excellent talk, and the panelist Dr. Sridevi Madam and Dr. Ganeshan sir for their excellent contribution to this talk, and all others, specifically Dr. Devigan sir, Professor Devigan sir, and everybody who has participated in the discussion. Thank you very much. Thank you. Thank you, Rajesh Babu, for the nice organization for this. Thank you. Thank you.
Thank you, sir. Thank you very much.
Thank you very
one
much.
and all. Thank
Thank you,
you,
Dr. Rajesh, Dr.
thank you,
Suresh,
sir.
Dr. Arul Selvan sir, Dr. Ganeshan sir, for having given the opportunity to participate in this program. Thank you very much.
Thank you all. Thank you for all co-panelists, Dr. Sridevi ma'am and my dear friend Dr. Arul and Dr. Suresh Jaybalan and dynamic and dynamite Dr. Rajesh Babu. Call me other program also, sir. I will be interested to attend. It's very nice attending, and learning things will be very, very interesting to postpone dementia. At least we can learn neurosurgery also a little bit. Thank you very much for asking to join in this meeting. Thank you very much.
This meeting will be on stroke, sir, because stroke day is this month.
Okay,
Most
sir.
probably it will be on 31st, sir.
Okay, sir. Thank you, sir. Thank you very much. Thank you.
Thank you, sir. Thank you. Thanks for giving an opportunity.
Thanks. You can conclude, Rajesh.
Can we leave, sir?
Yeah, please.
Yes, sir. Yes, sir. We can leave. Thank you so much, sir.
Thank you, Rajesh.
Thank you.
Thanks, Babuji. நல்லா இருந்தது. Naveen, thank you for organizing.
Thank you, sir.
Very good. இப்பெல்லாம் ஒரு 400, 500 தான் நம்ம டார்கெட். நல்லா இருக்கு டான்ஸ் நேம். இது நம்ம இது பார்ட்டிசிபென்ட்ஸ் நம்பர்ஸும் குறிச்சு வைக்கணுங்க டான்ஸ் இதுல.
இல்ல வருங்க, அது வரும். நாம வந்து கடைசியில வந்து டேலி பண்ணும்போது இட் வில் கம். நாங்க அந்த லிஸ்ட் வச்சிருப்போம். கடைசியில எங்கிட்ட இருக்கு லிஸ்ட் இருக்கும். எவ்ரி மந்த் எவ்வளவு பேர்
more than 500 போச்சு. Now it is more than 400. It's a very good
620 sir. 620 sir last time.